Welcome to the AS and Kidney 360 podcast. I am Anil Agarwal, Professor of Medicine in the Division of Nephrology at the Ohio State University Wexner Medical Center in Columbus, Ohio. I am joined by my colleague, Dr. Khaled Boubes, Assistant Professor of Medicine in the Division of Nephrology.
Hi, Dr. Agarwal, and thank you very much. Hello, everybody. Today we will discuss the debate in nephrology entitled Should Buttonhole Cannulation of Arteriovenous Fistulas Be Used?, published in Kidney 360 this May. Dr. Agarwal, dialysis fistula cannulation techniques remain controversial and a subject of debate. Can you briefly describe the difference between the buttonhole and the rope ladder cannulation techniques for arteriovenous fistulas?
Sure. Cannulation is an art that has to be practiced and perfected to cannulate a dialysis fistula 6 to 10 times a week, depending upon the frequency of dialysis. Usual recommended approach for decades has been to rotate both arterial and venous cannulation sites along the length of the fistula to allow for healing of the sites between dialysis sessions. This is the site rotation or rope ladder technique. In contrast, another technique of cannulation comprises of cannulation of exact same site every time to develop a tract that can eventually be cannulated using a blunt needle. This is the constant site or so-called buttonhole technique. There are advantages and disadvantages of each technique.
So what are the potential advantages of a buttonhole cannulation?
That's a great question, Dr. Boubes. Buttonhole technique was developed in 1970s primarily to reduce pain, complications, and interventions related to cannulation in fistulae while improving cannulation success and patient comfort. I must mention that the studies of these outcomes are small with variable methods and results, making them controversial and inconclusive. Perhaps the most important advantage of buttonhole technique is to make the cannulation of fistulae that have deep or tortuous segments with only a few accessible sites even possible. In the absence of easily accessible sites for site rotation, these fistulae could either be infiltrated repeatedly or end up being abandoned, requiring another access, which is frequently a catheter. Cannulation of areas of fistula repeatedly in the same vicinity, so-called area cannulation, also has the risk of developing aneurysms by weakening the walls of vein and is not recommended. Thus, careful constant site cannulation can enable use of such fistulae, and this is a valuable technique in patients who self-cannulate either in center or at home to ensure successful cannulation. This may be even more relevant now that there is ever more emphasis on home therapies.
So what are the factors which determine the success of buttonhole cannulation?
Well, motivation and expertise of the cannulator and adherence to aseptic protocol are the most important factors for successful buttonhole cannulation. The cannulator has to carefully adhere to a constant angle, depth, and direction of needle and proper position of arm with a tourniquet placement. Also, prior to cannulation, the overlying scab removal should be done properly following a protocol. Further, the needle that is used to remove a scab must never be used for cannulation, or the skin bacteria will be introduced into the bloodstream, increasing the risk of bacteremia.
So what are the potential risks associated with buttonhole cannulation?
The most important risk of buttonhole cannulation is development of local and systemic infection. It is easy to imagine that colonization of the site with the skin bacteria, as well as high prevalence of nasal carriage of staphylococcus in dialysis patients, make introducing infection rather easy via a buttonhole. However, use of personal protective equipment, aseptic precautions in scab removal and cannulation, with appropriate post-cannulation site care protocol can reduce the risk significantly. Repeated cannulation at the same site could also cause stenosis or aneurysm development in the fistula, which should be carefully monitored.
So how should a nephrologist decide whether a given patient is suitable for buttonhole cannulation?
Appropriate patient selection is of utmost importance in subjecting a patient to buttonhole cannulation. Nephrologists should consider fistula characteristics and use buttonholes for fistula with short length and tortuosity with limited accessible site. Patient needs, support structure, and comorbidities should also be considered in making this decision. For example, those with hand tremors, poor vision, and with indwelling prosthesis are not ideal for buttonhole technique. A meticulous protocol for training patients for buttonhole cannulation should also be utilized. Finally, the optimal strategy would be to use buttonhole cannulation as a valuable tool in the toolbox that should be used prudently to utilize otherwise difficult to cannulate AV fistulae only in properly selected individuals. Improper use of this technique can have potentially serious consequences.
Well, thank you very much, Dr. Agarwal, for this very valuable discussion. Thank you very much, everybody, for joining us for this Kidney 360 podcast.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare provider if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.